Welcome back to the Deep Dive. Today, we are stripping things right back. We're talking pure, high-yield revision.
Yep, all signal, no noise.
Exactly. So if you're a resident prepping for your boards, specifically the FRCS, or you just want to sharpen your trauma knowledge, you are in the right place.
Right.
We're tackling the face today.
Specifically the central face. We're going to cover the full spectrum of nasal trauma. So we'll start with the common nasal fracture, and then we're going to pivot hard into the complex high-energy injuries, the nasoorbital-ethmoidal complex, or NOE fractures.
So we're going from a weekend rugby injury to a high-speed dashboard injury.
That's it. And for the exam, you have to know the management for both, because mixing them up is, well, it's an instant fail. You've got to know when to wait, when to operate, and exactly which tools to ask for.
Okay, so before we dive into the anatomy, let's just handle the housekeeping up front. If you're using these deep dives to help you pass your exams, make sure you press that follow button. We have a lot of specific trauma topics coming down the pipeline, and you really don't want to miss them.
And if you learned something useful today, please rate the show. It genuinely helps us keep this going. Also, we build this for you, so if there's a specific topic, orbital floors, mandibular fractures, leave a comment. Tell us what you want to hear next.
One last thing. This is the rapid-fire revision. We're sticking to the facts, the classifications, the protocols. If you want to hear how this stuff actually plays out in a real trauma bay, the decision-making, the journal club, the clinical cases, you'll need the premium subscription.
Right. That's when we take the theory and apply it to real-world scenarios. It's where all the nuance lives. But for now, let's build that foundation.
All right, let's do it. Let's start with the basics. Nasal fractures. Just how common are these?
Incredibly common. It is the #1 most common fractured facial bone. The nose, it projects out from the face. It has very little protection. So if there's facial trauma, the nose is almost always involved.
So a patient comes in, the nose is swollen, it's crooked, and usually there's blood everywhere. Aside from the obvious airway stuff, what is the primary safety check? The one thing I absolutely have to look for before I do anything else.
You have to look inside. You must perform an intranasal examination. It is non-negotiable. You're looking specifically to exclude a septal hematoma.
And why is that the do not miss diagnosis?
It's because of the anatomy of the septum. The septal cartilage, it relies on the overlying mucoperichondrium for its blood supply. It doesn't have its own vessels.
Oh, okay.
So if you get a hematoma, a collection of blood between the cartilage and that lining, it lifts the lining off.
So it effectively suffocates the cartilage.
Exactly. It cuts off the nutrient supply. If you miss that, the cartilage becomes necrotic and it dies. The patient comes back later with a perforated septum or a saddle nose deformity because the structural support has just dissolved.
Or worse.
Or worse, it gets infected and forms an abscess.
So if you see a boggy purple swelling on the septum, you drain it immediately.
Immediately. You cannot wait on that.
Okay, let's say the airway is clear, there's no hematoma. The patient, they always expect an x-ray. They want to see the break. What's the rule here?
The rule is, don't do it.
Just don't.
Radiological investigation is generally not required for isolated nasal fractures.
That feels really counterintuitive to a lot of people. Why aren't we imaging a broken bone?
Because it just doesn't change your management. A nasal fracture is a clinical diagnosis. Look, if the nose is clinically straight and the patient can breathe, you're not going to operate just because you see a crack on an x-ray.
Right.
And conversely, if the nose is sideways, you're going to fix it regardless of what the x-ray shows.
Treat the patient, not the picture.
Precisely. Plus, old fractures and suture lines can look like new breaks, which just confuses everything. Save the radiation, save the costs.
Okay, so we're diagnosing clinically. But for the boards, we still need to be able to classify what we're seeing.
Yeah.
We use the AO craniomaxillofacial classification. Can you break that down for us?
Yeah, it sounds complex, but it's actually very logical. There are 4 types. Type 1 is a laterally displaced fracture.
And this is the most common one, right? The classic punch.
Yes. Imagine a right hook to the side of the face. The force comes from the lateral side, pushes the nasal bone over. One side gets depressed, the other might bow out.
Got it. Type 2.
Type 2 is a posteriorly depressed fracture. This is a direct blow from the front think hitting a steering wheel or a headbutt. The nose is smashed backwards.
Okay.
And this is important because type 2 is often associated with those NOE fractures we'll get to later.
Right. So lateral force is type 1, direct force is type 2. What about type 3?
Type 3 is a disarticulation of the upper lateral cartilage. The bone itself might not even be broken, but the cartilage has popped off its attachment to the bone. It can look like a depression, but it's really a soft tissue failure.
And type 4?
Type 4 involves the anterior nasal spine. That's the little bony spur at the base of the nose right above your lip. If that fractures, it's usually associated with a septal dislocation. The whole base of the nose just feels unstable.
Okay, so we've got our diagnosis. Let's say it's a type 1A, standard crooked nose. Patient's in the ER, it's swollen, they're upset. Do we fix it right then and there?
Usually no, and this is what we call the timing dilemma. Immediate reduction is very difficult because of the acute swelling. I mean, if the nose is puffed up like a balloon, you just can't accurately judge the contour.
So you think it's straight, but then the swelling goes down and you've missed it.
You've missed the mark, exactly.
So we wait. What's the window?
The sweet spot is roughly 10 to 14 days.
Why that specific range?
Well, you're threading a needle. You need to wait long enough for the edema to subside so you can actually see the bones clearly, but you have to operate before the bones start to knit together.
Before bony union occurs.
Right. So at 2 weeks, the bones are still mobile enough to move, but the swelling is way down.
Okay, so we bring them back at day 12. We're doing a closed reduction. This brings us to the instrument Viva, classic exam station.
Yep. They put a tray of tools in front of you and ask you to name them. You can't just say the pliers.
No, you've got to be precise. Let's walk through them.
Okay, first you have Walsham's septum straightening forceps. These are the ones with the straight paddle-like blades.
And despite the name septum straightening, we don't use them on the septum, right? That's the trick.
Correct. That's the classic trick question. Walshams are used to grasp the nasal bones, the lateral walls, to rock them back into place.
I've heard a mnemonic for this. Walsham for wall.
That's the one, Walsham for walls. The second instrument is Ash's septum straightening forceps. These look different. The blades are angled.
And Ash is for?
Ash is for the septum. It's designed to grip the septal cartilage and straighten it. So, Walsham for walls, Ash for septum.
Perfect. What's next on the tray?
Next is the Boyes nasal fracture elevator. It basically looks like a blunt metal stick or a sort of heavy-duty spatula. You slide it up the nostril, under the depressed bone, and just lever it upwards.
And to see what you're doing.
A Killian's nasal septum speculum. It's a long-bladed speculum that holds the nostril open and protects the rim of the nose while you work.
So, Walsham, Ash, Boyes, Killian. You snap the bones back, then what?
Then you pack the nose internally to provide support and stop bleeding, and you apply an external splint, usually plaster, or a thermoplastic cast to protect the reduction while it sets.
Okay, now what happens if we miss that window? Patient shows up 3 months later. The bones have healed, but they're crooked. We're in the late phase.
Now you have a much bigger problem. This is no longer a fracture reduction, it's a reconstruction. The bones have united. You can't just crack them back with forceps.
Oh, what's the fix?
You need an osteotomy. You have to take the patient to the OR for a formal rhinoplasty using chisels to re-break the bones in a controlled way. It's all about restoring the airway and the aesthetics. It's a significant operation compared to a simple closed reduction.
All right, let's shift gears. We're leaving the bar fight nose behind and moving to something much more dangerous. Let's talk NOE fractures.
This is where the difficulty curve really spikes. NOE stands for nosorbidoethmoidal fracture.
Just breaking that word down, nose, orbit, ethmoid, that tells you this is a central face smash.
Exactly. These injuries require significant force. We're talking high-speed motor vehicle accidents, dashboard injuries, that kind of thing.
And because of that force, these rarely happen in isolation.
Correct. If you've hit the face hard enough to crush the ethmoids, you have probably damaged the surrounding structures. You have to look at the frontal sinus, the medial wall of the orbit, and the floor of the anterior cranial fossa.
That proximity to the brain raises some pretty serious red flags. What are the critical exclusions here?
There are two massive ones. First, you must rule out a CSF leak. The cribriform plate, that thin, sieve-like bone separating the nose from the brain, is right there. If it fractures, you have a direct connection between the nasal cavity and the subarachnoid space.
Which means a high risk of meningitis.
Yes. So if there's clear fluid dripping from the nose, you have to confirm if it's CSF. Second, you have to assess the nasolacrimal system, the tear ducts. They run right through this NOE complex. If they're crushed or severed, the patient will have permanent tearing issues.
But the centerpiece of the NOE diagnosis, the thing that really defines the classification, is the tendon.
The medial canthal tendon, or MCT. This is the anatomical anchor that holds the inner corner of your eyelids in place against the nasal bone.
And if that anchor is lost?
The eyelids drift outward. The distance between the inner corners of the eyes widens. We call this traumatic telecanthus. It gives the patient a very distinct, flattened look across the bridge of the nose.
So the Markovitz classification, the gold standard for these, is entirely based on the status of this one tendon.
It is. It basically asks two questions. Is the bone broken? And is the tendon still holding onto that bone?
Great, let's break it down. Markovitz type 1.
Type I is the best case scenario. You have a single large fragment of bone that has broken off, but crucially, the MCT is still attached to that large fragment.
So the tendon is holding onto a piece of bone that's big enough to be surgically useful.
Exactly. It's a puzzle piece you can put back.
Okay, type 2.
Type 2 is where we see comminution. So the bone in the NOE area is shattered into smaller pieces. However, the specific flake of bone that the MCT is attached to is still distinct and large enough to be used.
So it's a shattered puzzle, but the piece with the tendon is still salvageable.
Right. You can typically wire or plate that specific fragment, but the surrounding bone is weak. These cases often need bone grafting for dorsal nasal support because the whole structural integrity is gone.
And finally, type 3.
Type 3 is the disaster. The bone is extensively comminuted, just shattered, and the MCT is detached from the bone. It's an avulsion injury.
So the tendon is just floating free.
Yes, there is no bone fragment left on the tendon to screw into.
That brings us to management. I'm assuming we aren't waiting 14 days for the swelling to go down on these.
No. These are complex reconstructions. The general principle is open reduction internal fixation, or ORF. You have to rebuild the skeletal box of the central face.
And the primary goal of that whole operation.
The primary goal is the accurate repositioning of that medial Kumphal tendon. If you don't get that right, the telecampus is permanent and it is very hard to fix later.
To get to that area, you need exposure. You can't just go up the nostril for this.
No, you need to expose the skeleton. It's usually a combination of incisions. You'll go through the mouth, an upper buccal sulcus incision to get to the lower midface. You'll make a cut in the lower eyelid transconjunctival to see the orbital floor.
And to see the top of the nose.
Often, you'll need a coronal incision. That's a cut from ear to ear across the top of the head to peel back the forehead skin.
That sounds aggressive.
It is, but it's often the only way to get a true view of the nasofrontal suture and the ethmoids, especially in type 2 and 3 fractures. For a simple type I, you might get away with a smaller incision, like an extended globular approach, but you need to be ready to go bigger.
Once we're in, how do we fix the bones? Let's talk fixation strategies. Start with type I.
For a type I, you've got that large fragment. You just need to immobilize it. You usually place a mini plate between the fragment and the piriform aperture.
The nasal opening.
Right. If that isn't stable enough, you'd add a second point of fixation up at the nasofrontal suture at the forehead.
So 2-point fixation usually does it. What about type 2 and 3?
These are unstable. The bone is shattered. You need 3-point fixation to triangulate the stability. Point 1 is the junction with the frontal bone. Point 2 is the inferior orbital rim, and point 3 is the piriform aperture.
You're essentially building a frame around the whole injury.
Exactly. But here is the critical part for type 3. Remember, the tendon is detached. You've built the frame, but the tendon is still floating. You have to physically reattach it.
How do you attach a soft tendon to shattered bone?
You don't attach it to the shattered bone. You usually have to anchor it to the other side of the face. We use a transnasal wire.
Walk us through that.
You drill a hole through the stable bone on the opposite side, or the newly reconstructed side. You pass a wire all the way through the nasal septum, grab the tendon, and pull it in towards the midline.
Think like a pulley system.
Exactly. You are mechanically cinching the eyes back together. If you don't do this, the orbicularis muscle will just pull the tendon outward again.
Is there an alternative to the wire?
In some cases, if there's stable bone deep in the orbit, you can use a specific bone anchor, basically a tiny screw with a suture attached to hold the tendon, but the principle is the same. You must actively re-anchor the campus.
So let's zoom out and recap the big picture here. We have two very different injuries.
Right. On one hand, you have the isolated nasal fracture. The strategy there is patience. Wait for the swelling. It's a closed reduction. Remember your tools. Walsham for the walls, ash for the septum.
And on the other hand, the NOE fracture.
Which is immediate complex surgical planning. You're worried about the brain, the tear ducts, the position of the eyes. You're classifying based on Markovitz and the status of the tendon. And you're likely doing a major ORIF with a coronal flap and transnasal wiring.
That is a solid overview. If you want to actually see what a transnasal wire looks like on a post-op CT, or how we decide between a bone anchor and a wire in a MISI Type 3, you need to listen to the Clinical Cases episode.
That's where we really apply this. We take a hypothetical patient, walk through the trauma bay presentation, and discuss the operative plan step by step. We talk about the pitfalls, what happens when you over-tighten the wire, what if the bone graft slips.
So go subscribe to the premium feed right now so you don't miss that. And please take 2 seconds to rate this show. It helps other residents find these deep dives.
And here's a thought to leave you with. We talked about type 3 NOE fractures where the bone is comminuted, it's pulverized, and we rely on bone grafts to rebuild the nose. But we know bone grafts resorb over time. If we're anchoring the patient's appearance and airway patency to a graft that might shrink by 30% in 5 years, how does that change the long-term prognosis? Are we setting these patients up for a delayed collapse that we aren't tracking because we discharged them too early?
Something to think about. Thanks for listening, and we'll see you in the next deep dive.